Hello and welcome to this PACES23 webinar. Firstly, an apology for the delay starting. We've had some technical issues and we do apologise for that. I'm Stuart Hood, Associate Medical Director for Clinical Exams and Chair of the Clinical Exam Board at MRCP UK, and I'm joined by my friend and colleague.
I'm Tanzim Raza. I'm currently the International Medical Director for MRCP PACES exam, but I'm involved with the development of exam as it was PACES 2020 since 2016.
So it's now well after 2 p.m. in London, and we recognise that for some of our international friends and colleagues it will be well into the evening. So a very warm welcome to you, and thank you, each and every one of you, for attending. The format of this webinar is for approximately 30 minutes of recorded presentations, followed by a live question and answer. So please feel free to submit questions and we'll try and answer them as they appear. If there are some that we don't answer, we will endeavour to reply to them personally in due course. Some parts of the webinar will be more relevant to examiners, others to candidates, but we hope that we mutually beneficial in preparation for the PACES23 exam, which will start in the autumn of this year. This event is being recorded, so you will be able to watch it at your leisure. In addition, there are a lot of additional resources on the PACES23 website, including video examples of the new scenarios. So I would encourage you to visit the website and review that material. In terms of the actual presentations, I will say a little bit about why we're changing the exam, but what remains the same. Tanzim will talk us through what's changing in the new encounters and why we believe there are improvements to the exam. I will talk about the marking scheme and the changes to the marks, and a little bit about changes to the mark sheets. And then there'll be a slide which will be relevant to hosts, just a kind of summary as to what the host needs to consider about if they are hosting PACES23. We'll mention a little bit about a 9-examiner protocol, because in recent times through the COVID pandemic, we've had late call-off due to examiner illness. And rather than cancel the exam, we have a format which allows us to run the exam with only 9 examiners. And finally, we'll say a little bit about academic misconduct and just a reminder of potential consequences. So without any further delay, once again, apologies for the delay in starting this, but we can now move on to the videoed recordings of the PowerPoint presentations, and we'll join up with you after these have been shown. Thank you.
Many of you will be familiar with the current PACES format and may wonder why we are changing the exam. In the next few slides, I will provide the rationale for changing the exam, and I will also take the opportunity to emphasise that there are significant elements of the carousel which remain unchanged. Let's deal firstly with why we are changing the exam. In any clinical exam, we need to ensure that we remain relevant, fair and up to date. We need to reflect changes in postgraduate medical education, training and assessment, and indeed we need to reflect changes in the workplace. And as part of all of our quality control at MRCP UK, it's now over 10 years since we last reviewed the exam, and we feel that a restructuring of the exam is merited at this time. At the outset of reviewing a change to the PACES carousel, 5 tests had to be borne in mind. The exam clearly had to remain academically valid. It needed to be reliable, but it needed to be deliverable. Importantly, we have a large number of international partners, and the exam had to be appropriate to their needs. And of course, we needed to fit it within a sensible business model. So let's look at old versus new, what is remaining the same, and what is changing in PACES23. I will deal with what remains the same, and my colleague Dr. Tanzim Raza will illustrate the changes in PACES23 in a subsequent presentation. So what is remaining the same in PACES23? The exam will continue as a 5-station carousel, with each station lasting 20 minutes. There will continue to be 5-minute intervals between stations, and therefore the carousel in entirety will last approximately 125 minutes. There will continue to be a 3-point marking scheme: unsatisfactory, borderline and satisfactory. We will continue to have 2 independent examiners at each station, and the very important process of calibration will remain unchanged. We will continue to assess the same 7 skills: Skill A, physical examination; Skill B, identifying clinical signs; Skill C, clinical communication; Skill D, differential diagnosis; Skill E, clinical judgment; Skill F, managing patient concerns; and Skill G, maintaining patient welfare. We also have retained clinical system examination, and candidates will be asked to examine a patient with a respiratory complaint, an abdominal complaint, a cardiovascular complaint, and a neurological complaint. Most importantly, I wish to emphasise that the standard of the exam will remain unchanged. I show this slide briefly, illustrating the PACES23 carousel on the left in comparison to the current PACES carousel, and I think it illustrates quite nicely the similarities between the 2 carousels. It is a process of evolution rather than revolution.
So I'm going to explain what changes are being brought into PACES23. You heard what is remaining the same, and I will describe what is changing. If we look at the current carousel, go through each station and understand what is changing. Station 1 currently is a clinical examination station with abdominal and respiratory patients, 10 minutes with each patient. Second, Station 2 is a history-taking station. Station 3 is a cardiovascular and neurological examination station. Station 4 is a communication skills, and Station 5 has 2 brief clinical consultation with integrated history and examination for 10 minutes each. So looking at these stations, the things that are changing is first, Station 2. It was felt that isolated history taking without examination and then suggesting differential diagnosis, etc., was rather unreal, and that is being modified. Secondly, Station 4, a 20-minute encounter to assess communications and ethical issues, was considered rather long, and certainly the 5 minutes interaction between the candidate and examiner did not seem to add much to the examiner's assessment of candidate skills. And finally, Station 5, with 2 integrated history and examinations stations, it was felt that it was quite rushed, although it was also felt that it is very real, close to the real life, but 10 minutes were far too short. So now I will explain how these new encounters are being introduced. So this is the new carousel. Looks very similar to the previous one, but what is different is on the Station 1, the candidate will start with the communication station, but only for 10 minutes. Then they will examine a respiratory patient as they currently do. Station 2, the history taking, is now an integrated clinical station where they will take history and examine the patient in 15 minutes time, and then there will be examiner-candidate interaction for 5 minutes. Station 3 will remain unchanged with 1 cardiovascular and 1 neurological examination patient. Station 4 is similar to Station 1 with the communication scenario for 10 minutes and followed by 10 minutes of abdominal examination. Station 5 is another integrated history and examination station similar to Station 2. So these new scenarios, I will explain those new scenarios in the next slide. The new encounters at Station 1 and 4 are similar to Station 4, but the difference is there's only 10 minutes patient and surrogate interview with candidate. There's no candidate examiner interaction. The examiners will make assessment and award marks on the basis of their observation only. It is recommended that the examiners will give a warning at 8 minutes to say that 2 minutes are remaining, and the candidate will continue to have 5 minutes of reading time before they enter the station. As far as the themes are concerned, the current themes are being retained, which include communications, explaining diagnosis, ethical dilemmas, duty of candor, drug errors, and shared decision making, etc. Scenarios will still be provided by the MRCP Central Office. Scenario writing group has been active and have already banked a fair number of scenarios ready for the next diet, and Scenario Editorial Committee have already been reviewing some of these scenarios and will continue to review them to make sure that appropriate elements of curriculum are tested and they also remain culturally appropriate for international centers. Other themes like telephone consultation, multidisciplinary team making, discharge planning, etc. are also being added to these scenarios. The new encounters, integrated history and examination stations 2 and 5 are that there will be a reading time for 5 minutes outside the station, and then the candidate will have 15 minutes to obtain history from a patient or a surrogate. They will have to do the physical examination and identify clinical signs. They would be expected to address patient concerns and advise on their management. And again, at 13 minutes, the examiner will give them an advisory warning that 2 minutes are remaining. And then there will be 5 minutes of interaction between the candidate and the examiner to assess all 7 skills. The new scenarios at Station 2 and 4 will be based on real patients with real physical signs. So it is expected that at least initially, the scenarios will have to be written by the host. The center will provide a guidance document. The patients or surrogate will be able to give history, but the candidate will examine the real patient. And the scenarios will be submitted for vetting to the respective college or to the Federation for International Centers, similar to what happens currently for brief clinical consultation. At the same time, the center office will keep some Station 2 scenarios on the standby. If a host finds a patient with appropriate physical signs and history, then it is possible that some of the bank's current Station 2 scenarios may be used. So these are the two carousels side by side to demonstrate the similarity and the difference. Thank you. It will be helpful to review the work and the effort that has gone into improving PACES to PACES23. So here's the timeline of development of PACES23. Back in 2015, the Clinical Exam Board was tasked to review PACES as it was then. And in 2016, August, a short life working group was formed, which met over 2016 and 17 and proposed changes. Those changes was tested in proof of concept studies in Hull and in Edinburgh during 2017, followed by pilot exams in London and Edinburgh in July and August of 2018. By the end of 2018, we were ready to submit those proposed changes to our regulator, General Medical Council, and that was done in December 2018, and approval was obtained. All preparations were set in place to introduce PACES 2020, as it was called then, in the autumn of 2020. But unfortunately, everything had to be put on hold with the advent of pandemic. When the working group first met, it very quickly realized the PACES as it is now has lots of inbuilt strengths which were decided to be retained. First, the strength is that we use real patient with real physical signs for clinical examination, and that had to be retained. Direct observation of each encounter by two independent assessors marking their assessments independently was also felt to be retained, and non-compensated skill-based assessment methodology also is seen as a strength and has been retained. This is all underpinned by quite big and very efficient infrastructure in the background which supports written material and quality assurance, etc. So the improvements that have been made are, number one, there will be two communication scenarios instead of one. The way the carousel has been rejigged, that will ensure that any candidate will only have to read one scenario while they're waiting outside the station, rather than current two scenarios at station 5, which sometimes leads to some confusion. The other improvement has been made that we've introduced two 20-minute integrated history and examination stations. And the way carousel has been rejigged will ensure that 8 out of 10 examiners will test all 7 skills instead of only 2 currently at station 5. So this is the current carousel, and you can see in the bottom line the number of skills tested by each examiner, maximum 7 and minimum of 4. With the new structure, all pairs of examiners will test all 7 skills except for those at station 3. So currently, if you're examining at station 5, you make 14 judgments on a candidate, whereas examiner at station 4 will only make a total of 4 judgments. With the new structure, there'll be more even distribution by the examiners in terms of number of judgments that each examiner will make. The minimum number of judgments with the new structure will be 7 and maximum will be 10. And as I said before, 8 out of 10 examiner will assess all 7 skills. It is felt by the psychometricians as well that this will increase the validity and reliability of our exam. This rather busy slide, but if you look at the bottom part of the slide, PACES 23 and the current just shows the distribution of number of judgments and marks awarded by each examiner. And with the new structure, the total mark available would be 168 instead of current 172. We're losing 4 marks on skill D, but as I said before, with the more even distribution of number of judgments made by each individual examiner, we feel that this will improve the validity and reliability of exam. And this is the current Carousel 23 as is being introduced in the next slide. Thank you.
In PACES 23, the marking scheme will remain the same, but the number of available marks will change, and we have made some minor alterations to the mark sheets. We will continue with the same 3-point marking scheme in PACES 23. Satisfactory will score 2 points, borderline will score 1 point, and an unsatisfactory mark will score 0 points. The PACES23 marking scheme will assess the same 7 skills in the current carousel. To pass the exam, you must pass all 7 skills and reach a total threshold score. As we will see in the next slide, there are fewer marks available in PACES23. The minimum score to pass all 7 skills will be 113, but to pass overall you will need 127 compared to 130 in the current carousel. This slide compares and contrasts the current PACES mark scheme with that of PACES23. In the current format of the exam, there are a total number of available marks of 172. To pass the exam, a candidate must pass all 7 skills and reach a total threshold score of at least 130. In PACES23, there are 4 fewer marks for differential diagnosis. The other 6 skills remain unchanged and the pass mark for those skills remains unchanged. In PACES23, therefore, there are a total of 168 available marks, and to pass the exam, a candidate will require to pass all 7 skills and reach a total threshold score of at least 127. MRCP UK must commit to ensure that a candidate who would have passed the current PACES format will pass the new PACES23 format. That is to say that we continue to pass the right people and that no candidate is advantaged or disadvantaged. This is a patient safety measure. For this reason, and to ensure that we have comparable outcomes for candidates, we will need to monitor the first 2 to 3 diets of the new format very carefully. The majority of candidates will therefore need to wait between 3 and 12 weeks for results, and an average wait of around 8 weeks may be anticipated during these 3 diets. In addition to the new encounters in PACES23, a number of minor changes have been made to the mark sheets. The layout will be familiar to most examiners and candidates, but it is worth pointing out some changes. Candidates will no longer write their name, but will now fill in their RCP code in addition to their candidate number. Examiners will no longer need to print their name and sign each mark sheet. Instead, they will fill in their examiner number and write their initials in the assigned box. Examiners will also be asked to record on the mark sheet whether this encounter was the candidate's starting station. The clinical skills A to G will now be listed alphabetically on the mark sheet, and some of the descriptors have been updated. Examiners, please only write comments in the designated comments box. Please avoid circling or highlighting any of the descriptor text to justify your mark. Any remarks beside the descriptors can result in the scanner rejecting the mark sheet, in which case a manual workaround is required. This process may be prone to human error, and we wish to avoid such situations. Thank you. At MRCP UK, we greatly appreciate the time commitment and efforts of our hosting centres. We hope that you will find hosting PACES23 no more onerous than the current carousel. The colleges will provide you with summary host information and a checklist of things to consider in the lead up to the exam. If you are a host examiner, we will request that you source patients for the respiratory, abdominal, cardiovascular and neurological encounters, similar to the current PACES carousel. We will ask you to write scenarios for stations 2 and 5, the consultation stations. Guidance and templates will be given, but this will be a process similar to the writing of the current brief clinical consultations. We will ask that you source patients and or surrogates for stations 2 and 5. Communication scenarios at stations 1 and 4 will be issued centrally from MRCP UK. We will ask, however, that you source surrogates for stations 1 and 4 communication. Finally, could I ask that you have an overview of the entire carousel and avoid repetition of cases or particular diagnoses. Once again, thank you very much for your help in running PACES exams. On rare occasions, there may only be 9 available examiners at a PACES centre. We have standard operating procedures to deal with this eventuality, and I will emphasise the salient points for examiners and candidates. Running the exam with 9 examiners should only occur in exceptional circumstances, for example, late call-off of an examiner due to illness. If less than 10 examiners are available, candidates should be informed and asked to confirm that they have agreed to proceed by signing the sign-in sheet. Candidates should be offered the chance to withdraw, in which case an alternative exam place will be offered. The host and chair should identify an experienced examiner who could double mark at station 2 or 5, one of the consultation encounters. Please record on the centre incident form that there was a single examiner at that station. A second examiner should undertake calibration with the single examiner, and we recommend having an observer in the station with the single examiner to ensure fairness. The lone examiner will mark one sheet, but please ensure that identical marks are placed on the second mark sheet. If you are a candidate, you will be notified that there are only 9 examiners present. You will be offered the chance to withdraw and be given an alternative exam place. Please note we will try to ensure an alternative date in the same diet, but we are unfortunately unable to guarantee this. If you choose to proceed, you will indicate so in the sign-in sheet. A single examiner will mark you at station 2 or station 5, and their marks will be doubled. A non-marking observer may be present in the single examiner station to ensure fairness. If you choose to proceed with the exam, you cannot at a later date appeal the fact that there was only a single examiner at one station. Unfortunately, in recent years, we have encountered some cases of academic misconduct in PACES exams. I'd like to emphasise that we take this very seriously and we will always investigate. There are significant consequences for anybody found guilty of misconduct, and I hope by sharing the next 2 slides we can avoid any confusion. I wish to emphasise that by applying to sit the examination, candidates are deemed to have understood and agreed to respect and abide by all relevant regulations. These are included in the Candidate Code of Conduct available on the MRCP website. What constitutes academic misconduct? Any attempt to remove materials or content from an examination, any attempt to release content from any examination to a third party or commercial organisation. This would include Facebook pages, Twitter, or other social media platforms. Any attempt to communicate with another candidate, and any attempt to gain or pass on information about the contents of the examination in advance of the date of the examination. If MRCP UK suspects academic misconduct, an investigation will proceed. If, on balance of probability, it is determined that academic misconduct did indeed take place, there are several potential outcomes for that candidate. There may be no further action, There may simply be a written warning. It's highly likely that the case will be passed to the relevant regulatory body, which in the UK will be the General Medical Council. Results for an examination or part of an examination under investigation may be annulled or withheld, and this may include, in severe cases, any previous attempts. Finally, the candidate may be barred from entry to MRCP UK exams for a specified period. If you're a candidate, I wish you well in your upcoming exam. Thank you for watching this briefing.
Presentations. We hope you find them useful. We have had a number of comments and questions, and we will try and go through these. Some of the questions which have been submitted have actually been answered on the presentations, so we may not repeat information which has already been passed on for time purposes. Firstly, I'm going to pass to my colleague here, Tanzim Raza, to deal with some comments we've had about international places for PACES.
We're very aware of the problem that many international and even some candidates in the UK are facing to find a place for PACES exam. Pandemic has not helped, and actually the backlog is increased, but we're very aware of it. We're working very hard to increase availability of PACES spaces in different centres internationally. We're also working hard to open new centres. In the last year or so, we already opened 3 new centres, and another 3 or 4 are in the pipeline. So fully appreciate people having to wait longer, but we do have a priority criteria, and anybody who's nearing their eligibility stage, we try and prioritize that. So we are working on that.
So we'll move on to some specific questions now about PACES23. I would like to ask some advice on the average time allocation to each of history, examination and discussion with the patient. This is relating to station 2 and 5, the consultation stations. There is 15 minutes for the candidate to undertake questioning with the patient, examine the patient, discuss the patient with the patient, the management plan or the likely diagnosis. There is no stipulation as to how much should be spent, and that's at the discretion of the candidate themselves and may depend on the way the consultation leads. There's likely to be a 2-minute advisory warning after 13 minutes has elapsed, and that might be an indicator to some candidates that they wish to summarise things with the patient. But it's really up to the candidate. They can take on the encounter as and how they wish. In many respects, similar to the brief clinical consultations, where you can do a bit of examining as you're going along and asking some questions at the same time. Another question was with regard to, I think it's largely the previous station 5. Will there be a focus on particular topics such as rheumatology, dermatology, endocrinology and ophthalmology? Now, many of you who are as old as myself and Tanzim will remember that the old station 5 used to have 4 very, very brief encounters centred on these 4 clinical dilemmas. That was prior to the BCCs coming in. What I would say is that the exam is designed to test the internal medicine curriculum. So any candidate who is preparing for this exam should be prepared to encounter material which would be in the curriculum. And we very much map the content of all our exams in MRCP to the content of the internal medicine curriculum.
So the next question from Gia is about when is RCP planning to upload RCP sample scenarios in new format? Some scenarios have already been uploaded and the others are being prepared, and hopefully in the next few weeks it will all be available on the PACES23 website.
I would emphasise that on the PACES23 website, there is a videoed example of one of the new consultation encounters, and we have two video two of the station 2.5 consultations. One of them is done with the patient providing their own history. The other one is filmed with a surrogate giving the history on behalf of a patient. Now, if you're in the UK, this will be a departure from the normal, because in Station 5 BCC, usually the patient gives their own history. Internationally, it's very common practice that there will be a surrogate giving the history. The rationale for allowing a surrogate to give the history in the UK as well now would be that often surrogates are professional actors, and they can deliver the history in a very consistent manner. It's sometimes difficult for patients to deliver a history consistently, and also to deliver a history which is not exactly their own. And you will be aware that sometimes we modify the history of an encounter. It will still fit with the clinical signs, but it just allows the delivery of that history to be performed in a consistent manner, which helps in fairness to all candidates.
The other question, Stuart, is about passing and pass mark and mark sheets. You already told them in the presentation. The total mark is being reduced to 168, and the pass mark is stipulated to be 127 total instead of current 130. So that's a notional pass mark, as I alluded to in the talk about withholding of exam marks. Clearly, we need to ensure that no candidate is disadvantaged or advantaged. If, for example, after the first cycle of PACES23, we found that the pass rate had dropped dramatically, then that would be an indicator that there was something wrong with our standard, and we need to look at that and make appropriate adjustments so that the pass rate remains within historical norms. We wouldn't want a candidate to be disadvantaged and to have major fluctuations. So the intention is that the standard of the exam will remain the same, and a candidate who would pass the current PACES cycle, you should be able to pass the PACES23. You want me to take the next one? Ijaz Ahmed is asking, is there any difference in marking system? As you heard, same 7 scales, same pass, unsatisfactory, satisfactory, borderline, and just the total mark has changed a little bit. The next question
is the communication scenarios similar to earlier exams? In brief, the answer to that is yes. Many of the current Station 4 communication and ethics encounters are suitable as the new communication encounters. Some of them may have been shortened slightly, but in part of the review process, when we were looking at PACES 2020, we recognised that on a number of occasions at Station 4, candidates often finished early, and indeed the examiner-candidate interaction often didn't add very much to the marking scheme. The examiners had often made their decisions based on observation alone. So in essence, the candidate who is sitting communication and ethics encounter on the upcoming PACES diet, they will find that the scenarios which they encounter if they have to do a PACES23 will be very, very similar.
So the next question is from Savannah Gila, that he's from Indonesia, saying that unfortunately, we don't have a center there. You don't have to wait 5 years. As we said earlier, we're trying to prioritize, and hopefully we'll be able to accommodate you. It's not only in UK, you can also try in centers in India, and we're going to open a center in Bangladesh. Hopefully you will get accommodated one of those centers in the near future. We do apologize for you having to wait that long. The next question, for example, this one from, we talked about this. So Lax Vardhan is asking about station 2 and 5 minutes between the break, but that is not going to be any different. If anything, it will be less rushed.
Yeah, I mean, I think our experience very much, and a lot of candidates and examiners will say that the brief clinical consultation, station 5, is very time pressured. It's difficult for candidates to read two scenarios, and sometimes they may get mixed up with which patient they're dealing with. So station 5 was recognised pretty much universally. It was good for testing all the skills in an integrated fashion, which is like real life, but it was just very time pressure. I think candidates will find that when they have longer to talk to the patient and time to do a focused examination, then they'll probably find that this is not as difficult as a BCC. And clearly, when you come out of this station, you will have 5 minutes resting time, and you will have 5 minutes preparation time before you go into the station as well. So I think candidates will probably find that it will be a less onerous station than the current station 5. That certainly was the feedback when we ran pilot examinations of this new format. The candidates who helped us with these scenarios felt that it was better than the current brief clinical consultations.
That's quite important to re-emphasize. We piloted it, and the candidates were quite happier, and they felt it was better than the current station 5. Next question is very up my street, and it's Dipto Hazra, asking about whether going to be a PACES center in Bangladesh. I can confirm that I just got my Bangladesh visa today, and hopefully we're doing a fact finder in June, and within a few months after that, you will have a center in Dhaka if everything goes fine. This one from Lax Vardhan.
Is the post-exam briefing meeting going to work on the assumption that the pass mark is 127 to decide pass or fail for the candidate? Well, the first thing to say is that the post-exam briefing meeting is only indicative. The electronic candidate performance mark sheet, which is filled in, is indicative, and it gives the examiners on the day some feedback as to how candidates have performed, but it is not the final mark. The final marks are only determined when the mark sheets go through the scanner. So once the mark sheets have gone through the scanner, we will be withholding the results for at least about 90% of the marks until analysis has been done to ensure that there's stability. So the 127 pass mark is indicative. It's been based on just simple proportionalisation of the current marks.
Next one is from Basant. Thank you, Basant. About it would be helpful for chair to brief candidates before the cycle. Definitely, we strongly recommend, both in the UK and internationally, that the chair speak to the candidates. It also puts them at ease, and definitely talk about if there are going to be any difference in examiners or any specific things. So point taken, and we can re-emphasize in the next diet as well.
Yeah, thanks for that, Basant.
So this one for Raj Naval, Ranganathan. Are there any differences? You already answered that.
So the scenario templates are actually very similar, and they're based on the brief clinical consultations. But your college, if you're a host and you're being asked to write scenarios, your college will be able to give you material very similar to the Station 5 writing material. On a personal basis, I believe it's going to be potentially easier to write the new consultations compared to the brief clinical consultations. When we did the exam in Edinburgh as a pilot, some of the consultations we used were actually brief clinical consultations, but some of the history had been put back in. Many of us, when we write brief clinical consultations, we omit some of the history to make it fit within the timeframes. But I think where you've got a surrogate providing a history, it will be easier, and you'll be able to encompass more of the history. So, for example, as an example, you may put in a patient who has atrial fibrillation. The patient doesn't need to give the history. You could write a scenario such that the patient has become really breathless in the last 5-6 days, and perhaps one of the only clinical findings may be atrial fibrillation, but the assumption is that the atrial fibrillation may be new. So I think the writing of these scenarios may be easier, but you will be given guidance by the colleges. And if you are really struggling for ideas, your college may be able to provide you with some current Station 2 scenarios that are designed for history taking, and you may have a patient you think that patient could be suitable to be used and incorporate some physical findings in with the history.
While you've been talking, the questions coming thick and fast. Some we've already answered, but I'll take them as we speak. Fatima Toj Johara, about Bangladesh, I said yes, Bangladesh is very much on the cards, and hopefully I'm visiting next month to set up a PACES center and be up and running. Brunei, from Raj, Brunei is on the hold now. We're not going there anytime soon, I'm afraid. And the next one from Sadia in Saudi Arabia. Again, we had a first meeting. Saudi Arabia has been a bit difficult, but we are looking into that. We are aware of a large number of candidates there, and hopefully we'll be able to give you good news about that as well in very short time. Okay. You want to take ask him first?
Yeah, so I asked him by email. In Station 1, the communication topic, shall it be related to the respiratory case or is it separate? I should emphasise this, and our communications will, in due course, address this. But at Station 1 and Station 4, the communication encounter will be entirely separate from the clinical examination. So you will do a communication counter, and then you will move to a respiratory patient for examination. These two cases will in no way be linked. And that's a question that has come up in the past.
In the last couple of minutes, there have not been any more questions. We're still here, but we can just re-emphasize. Hopefully you've seen that it is an improvement. It's an evolution rather than revolution. The contribution of individual examiners, we feel very strongly about it, will increase the validity and credibility of exam. We also feel that the only one scenario being read will also be helpful rather than two. And the other thing is that out of 5 candidates, 4 candidates sitting outside will be reading a scenario rather than currently only 3 and 2 people sitting in Station 1 and 3 doing nothing. So these are the few things, and we are, for international centers, our chairs are running additional mock exams as well, which will also help train the candidates and the examiners. Another question has come from Rasin Amar. It's about Iraq. Again, I met with the international advisors of the London College for Iraq, and we are looking at it very carefully. And it's difficult to say when we might be able to actually start a center, but we are conscious of it, aware of it, and as I said, we're working on starting that station, hopefully there. Fatima has asked another one.
Let me just read this one.
She's asking, history and examination still remain focused, history and examination just like before, or previous Station 2? I think it's a mixture.
It's a bit of a mixture. I mean, I think we would be expecting a more detailed and thorough history in the new consultation encounters. It will be along the lines of the current Station 2 for history taking, but you'll be expected to examine and interact with candidate questions. So it's a little bit of an extended brief clinical consultation where there'll be a more in-depth history to be taken.
Another question has come through again from international, from Muhammad Saad. Is there going to be another center in Pakistan? We opened in Pakistan very rapidly, and I'm really indebted to Amir Ghafoor Khan, who I know is listening, to set up in Lahore and Islamabad. we will be in discussion, and hopefully we might open further centers. I mean, we know the demand in Pakistan is very high, but at least you have 2 centers, and it runs five days, 3 times a year. So we're trying our best to meet that backlog. Now, you want to take that one? Muhammad is Enamul. Okay, Muhammad Enamul Hassan Murta. Okay, so he's saying, please let us know what criteria is used to prefer the candidates get PACES exam center slots over others. In the UK, we have different prioritization criteria. I'll let you do that in a minute. But internationally, because of the demand, and as I said before, with the COVID, there being backlog, the priority is that given to people whose eligibility may be coming to an end. We do not want that eligibility to expire. So if those people have been waiting the longest, we try to prefer them to get that place. In different countries, it works slightly differently. Some countries have some ring-fence places for their own trainees, or from specific countries. But we are aware of the problem, as I said before, and we're working very hard to meet this demand. You want to the UK?
Yeah, in the UK, historically, we never had any problem with prioritisation or waiting list. Anybody who was resident in the UK applied, got a place. Clearly, when we had limited places during COVID, we had to prioritise, and we set out our prioritisation criteria, and they will be uploaded onto the website and communicated. But basically, we looked at where candidates were, if they were in a training programme, if they were near to a progression point, if somebody had been cancelled because of, for example, a COVID cancellation of a centre, or strike cancellation, priority would be given that way. Our hope would be that within the UK, we do not need to have any prioritisation, and anybody who is applying in the UK to sit in the UK would get a place. We can't obviously guarantee that just now, but that would be our hope, and that's what we'd be working towards.
This is from Tav Soor about the new communication station structures like the old station 2 and 4. No.
The communication stations will be very similar to Station 4. They will have very similar themes. They will be timed, or the scenario writing group and the scenario editorial committee have looked at a large number of the Station 4s, and they've decided which ones are usable in the new format, i.e. they're likely to be able to be accomplished and undertaken in the appropriate time frame, and that there is not an essential element of candidate examiner interaction. So Station 4 will be very similar. Station 2, the history-taking element will be similar, and they would expect a thorough and detailed history, but it will be coupled with examination time. And we wouldn't be expecting candidates to examine every system. The ideal would be that the history itself from the patient will dictate and point to which parts of the examination are appropriate, and that will be part of the skill that will be tested. But it's meant to reproduce the type of thing that a candidate would be seeing in their workplace. Is it somebody who's come up to an outpatient clinic with a less acute topic, a less acute complaint, or is it somebody who you're seeing in the medical assessment unit, where, for example, they may have presented with a limb weakness, and the history will dictate what part of the body would be examined.
Babinona 2004 at yahoo.com has asked 2 or 3 times about selection of international PACES examiner. It's not relevant to PACES23, but just to give you a little overview, we're not overlooking your question. MRCP is a federation activity. We have 3 Royal Colleges, and they all contribute towards international examination. As far as the international centre is concerned, we rely heavily and entirely and quite justifiably on our federation lead who know the local system and local examiners. So that system will need to continue. We talked about Nepal. Yes, we have already been for a fact finder. Actually, the first Pathfinder exam is scheduled in September. So we will be there in Medicity in Kathmandu. That has been chosen as a center for PACES. Inamul Haq Mujtaba, that we already answered about these priority criteria. And the next one, quite a lot of communications team, we just answered that. Bob and I have asked. So what about Kathmandu Center? I just said we are opening a center there, and hopefully the first live exam will be later this year. James R. If the result are held back to Diet 3 for checking purposes, will this mean everyone from Diet 3 will have previously applied for Diet 1, provisionally applied for Diet 1? Will this have a domino effect and many people we can accept?
This is a thing that we didn't encounter prior to COVID pandemic, but yes, we have had instances where candidates have had to put in provisional applications for the upcoming diet. It's not convenient for candidates, we recognise that. It's not convenient for candidate offices, they find it difficult to manage provisional applications and planning ahead. But by far and away the most important thing is that we ensure that the standard of the exam remains appropriate and that we are passing the right candidates. So it is one of the downsides. Whenever you change an exam, you have to make sure that there's equitable outcomes. And the last thing we would want is for the pass rate to drop dramatically. If you think about it, the cohort of candidates that sit PACES exams are roughly speaking of similar aptitude. And so if there was a sudden drop in the pass rate, it wouldn't be due to the fact that the candidates would have lesser ability. It clearly would be an issue with the exam itself. So it's important that we make sure that the exam retains the correct standard. One of the downsides may be that candidates will have to put in provisional places, but we would hope that we could minimise that by getting as many results out as possible before application windows open.
The next question from Moyed Mohammed Mamal about why some international centres take only local candidates. In some countries, MRCP is integrated with their local training program. So those people who in that training program, for example, Singapore or Hong Kong, they take priority and they can select their other candidates. And the arrangement is different from different hosts, and we have to comply with the host requests as well. Moving on, there's a question from Lok Manong, whether there will be difference between the two communications.
So in essence, the two communication stations will share great similarities. Similar timing, no candidate exam and interaction, 5-minute reading time. The themes, however, will be different. So, for example, you should not expect to get a Station 1 communication encounter, which is a breaking bad news, and then a Station 4 communication encounter, which is also breaking bad news. You would expect different themes to them so that we can test across the curriculum and test the skills of the candidate. We would not want to have repetition, but the actual format of it will be the same.
And then Asif is asking, may I know, will MRCP sample scenarios be available? Yes, we already answered, they will be available. Some are already uploaded on there. Any plans to open a center in Karachi? I discussed about Pakistan already, so hopefully just watch this space. Moving onward, there's another question about, is it possible, this is a Savannah Killer.
Okay. So the question is it possible for international medical graduate doctors outside UK to get a PACES seat in UK for PACES23? Well, clearly, historically and before the pandemic, there were some places available for international medical graduates outside the UK to come to the UK and sit the exam. Capacity issues have prevented us from allowing that so far. And again, that we're very much determined on UK priority places. I'm sure if we had more capacity than demand, then we would make these places available. But at the moment, I can't make any guarantees in that.
So hopefully in the near future, because historically people used to come from overseas, because of the current backlog, we are already back to pre-pandemic. So we would hope that in the near future, but we can't guarantee when it will be, but we will be accommodating international candidates in the UK as well. So again, Javeria is asking the same question about new scenarios. We said that were available. Karachi, we already discussed. Idris Khalid, if it's possible for the colleges to provide Station 5 scenarios where the hosts are getting trained? Yes. If you're a host or a chair or a federation lead, if you get in touch with the international examiners on their email, they will provide you with the scenarios. And we may need to discuss that, what you're planning to do. Muhammad Imanul Hassan Mohtaja, if an IMG applies for PACES in the UK, so he stays in another country, is it easy to get a slot for PACES exam as compared to applying? So we just answered that question, that at the moment in the UK, we are ring fencing places for our IMT candidates because of the COVID-related backlog. But now that we are reaching numbers similar to pre-COVID, hopefully we'll be able to accommodate you here as well. You want to take this from Amir Mizwadawi?
So it's in stations 2 and 5 with the examination. If there were different symptoms leading to different systems, should I examine in details that system or just target examination? So I think it's about responding to the history that the patient gives you. The host who will be writing these scenarios will be instructed not to have too many red herrings and not to lead the candidate to examine parts of the body which are not necessarily relevant. So it's all about the writing of the scenarios, where we would hope it would be pretty clear from the patient or the surrogate giving the history where the complaint is. As I said earlier, we wouldn't expect a candidate in that short period of time to have to examine 3 or 4 systems. And we wouldn't necessarily expect you to do this if, for example, the history alludes to a respiratory complaint. We wouldn't necessarily expect you to undertake a respiratory examination in the same way as you do at the pure respiratory encounter. We would expect you to target and look at the things which are most appropriate and to time your examination in order to fulfill the entire encounter. So we wouldn't expect you to do everything and do a full 6-minute examination. It will be entirely appropriate for you to do what's needful. And part of the calibration process, the 2 examiners will think, right, what do we really want a passing candidate to examine, and what do we want them to find? Are we happy if they don't listen to the heart? Are we wanting them to examine the abdomen in this case, for example? The 2 examiners will decide that at calibration, and they may give advice if the candidate is moving to examine a part that's not really necessary. They may, in order to assist the candidate, say you don't need to examine that part. That advice may be given. Just say you don't need to examine that, it's normal. And that might just be in order to help the candidate perform the task in the appropriate
It probably is fair to say when we did the pilot, we were aware of that. We don't expect you to do full inspection per patient as patient for every system. It's the only relevant bit that will help you in diagnosis, as Stuart was saying. Another question has come through from Fatima Tijara. Will there be less concern in communication and ethics station than before as time is less? No, on the contrary, it's more emphasis because you'll be assessed on communication or some aspect of ethics on 2 occasions. 4 skills will be tested one day, and but you'll be tested on 2 occasions. In fact, we are more keen to test communication and ethics in the PACES23 format.
Yeah, I mean, I think that emphasises so much of our job these days is communication, particularly communication with relatives and patients. And so it allows us to examine more material around communication, but it will be the same 4 skills. Skill C, communication. Skill E, clinical judgment. Skill F, managing patient concerns. And skill G, maintaining patient welfare.
The other question is from Mohammed about another center in Cairo. We're aware of pressure in Egypt. We're looking at center in Cairo, as well as possibly I've spoken to Maha and also possibly Professor Hossam, and also hopefully looking in other cities in Egypt as well. How to book for Pathfinder, but Bataria is asking, it depends on which country you are. It depends on the local federation lead. We nominate local examiners and they select who's going to be the candidate there. Bonia is asking another question. We already discussed it. We can't have reservoir or use that because to make a waiting list. We do try to have enough examiner for each center, and we leave it for international examiner for the local people, and also for the UK examiners sent from UK. This is the latest. We need to start with it. Yeah. Just bear with me, so because now I got the hang of it. Again, oops. Can you good idea about new clinical consultation? We already answered that.
Yes, we've answered that, and I think there are some comments about video. Can you provide videos of the new? Somebody said the new Station 5. I'd emphasise again that on the PACES website there is a sub-page, PACES23, and there is material there. There are about, I think there's about 13 videos which show not only the encounters. So there's one communication encounter which has been filmed, and there are 2 consultation encounters which have been filmed. One of those, the patient gives his own history. The other one, a surrogate gives the history on behalf of the patient. But we also show part of the calibration process. We also show some examiner comments at the end after they have done marking. It shows what they thought the candidate did well, and there are examples of scenarios which the candidate has performed well in. So it gives potential candidates the chance to see how a good candidate or a successful candidate would undertake those encounters.
That's an interesting question from Berkas Khadija about I would be grateful if you provide us with a clearer idea about telephone discussion and MDT in communication station. So in the UK healthcare system, I'll talk about multidisciplinary team first, that usually a medical patient's care is decided by various professionals that are part of that, like physiotherapists, speech therapists, even pharmacists and social workers, etc. It's a discussion about the patient condition and the plan collectively about how we're going to care, to plan their future care. So some scenarios may test some aspect of that. Currently, we do not have that in the stage. We don't have anyone in the bank, but that might come. We obviously will give plenty of notice before that is brought in. Similarly, telephone discussion is at the moment still an idea, and we don't have any scenarios there yet. And again, if there is, we will forewarn you through our website.
Yeah, the scenario writing group are currently thinking about new material which could be used, again, to reflect the everyday work of a training doctor. So it's development for the future rather than something that you need to be concerned about immediately.
Yeah.
But we think it's appropriate to try and test these things because it replicates the work.
And next question, Anil Kumar is asking whether this current station BCC 1 and 2 can be adopted for station 2 5. Absolutely. That needs a little bit more detail. You need to beef it up. Currently, we are always trying to truncate and make it much shorter to fit in the current 10 minutes. This will give you more flexibility, and same scenarios can easily be adopted.
Yeah. Yeah, I mean, I think if you are a host and you have written some B3C in the past, you may find that you want to look at these and say, well, is there any other history that I could add? You may have a patient who's very good at giving a history that's not necessarily their own, and you may choose to add some additional history to expand the encounter. Alternatively, you could ask your host college to provide you with a surrogate. I know that the Glasgow and Edinburgh colleges, and perhaps the London College as well, often uses professional actors who can deliver a very consistent history, and you can give them a script and just have the patient there to be examined. So you may find that some of your current BCC scenarios could be converted, and that's indeed what we did for one of the pilot projects in Edinburgh.
Amir Mazzawi is asking that your eligibility is coming to end in basis September 24. The candidate team is very well aware of everybody's eligibility criteria ending date, and they will go out of the way to try and accommodate you before your eligibility runs out. If God forbid it comes to that, communicate with them and they will try to make some arrangement for you. Ruhul Abir is asking that this new Station 5 videos, and you already said
they're mentioned. If you go to the PACES website page and down the left-hand side, you should be able to see the video exemplars.
Maisha Mifta, how the PACES places allocated, some candidates get placed in PACES Type 2 even when they pass Part 1 after you. That is frustrating. I fully share with frustration. It is depending on which country you may be in and how many places we may have available, and we try to give preference to people whose eligibility is nearing an ending. Idris Khalud.
At New Station 1, if the scenario is similar to the same condition as the actual patient, what should happen? So the two scenarios shouldn't be linked, and that's one of the things that we ask the host to have oversight of the entire carousel such that there's no repetition. But it's unlikely that the respiratory examination case will be very close or akin to the communication encounter. We would expect the communication encounter is dealing with some other issue, for example, a drug error, and then you move on to examine a patient with a respiratory complaint completely unrelated to that drug error.
The only example I can think of is that maybe breaking bad news about lung cancer, and the patient may having some pleural effusion or something. We'll try our best to avoid that kind of situation happening. So the next one is Judy Risk. I think you already answered about the specialties Station 5. We do not have any specific specialty. It can be acute or chronic presentation of a existing condition or new.
But we would encourage our hosts to try and think about the breadth of the curriculum and to include material which is not included in the exam elsewhere. So rheumatological conditions are clearly an option for the new consultation encounters.
And the next question from Liu Win Jane from Malaysia is quite interesting about communication and clinical examination. We are mandating for PACES23 that you will always start with communication first. As you say in your question, Liu, that because you just read the scenario, yes, that makes sense that you start with communication in Station 1 as well as 4. That is, if that doesn't happen, that will be breach of procedural.
We would consider it a procedural error. You should have your reading time and then go straight to the communication encounter. You should never have the reading time, do the clinical examination, and then be taken to the communication encounter. That should not happen. So at both Station 1 and Station 4, the communication encounter must always precede the clinical examination.
And the other question from Dr. Inamul Hassan Murtaja, how long will it take to know if they've got a Station? So they're asking how long will it take for them to know whether they got a slot for PACES in one center or the other. The way it works for international candidates is that you select 4 possible options, you give your priorities, and you're told, so you don't need to keep applying again and again. You apply one time, and we start that long time before the exam date, so you know exactly where you might get a place. So that is already in the system.
And that's just another couple of
yeah, so Spain,
questions.
we've been discussing it, although we're focusing on PACES23, but we fully understand there's an opportunity for people to ask about some other issues related to MRCP or PACES. We're very happy to answer them. So this is where Arif Khan is asking about if you're waiting for a long time. We're trying our best to get you accommodated as soon as possible. Again, when Arif Khan asking the same question, I talked about the criteria again and again. I think we have addressed those questions.
If you are an examiner watching this, as part of our remit, we've got to show to the GMC in the UK, since it's a UK licensing exam, we've got to show to the GMC that our examiners have been trained in the new format. So there will be a brief online package which should last around about 20 minutes, followed by a 20 question true or false questionnaire that all examiners will need to pass before they're allowed to participate in PACES23. It's not difficult. It will be very easy. The material will be very similar to today, really concentrating on the new encounters, sequencing encounters, and simple true or false. If you answer it incorrectly, you'll be told you've answered it incorrectly, go back and answer it. So if you are an examiner, you will be contacted about this in due course. Part of our problem is that we don't want to put material out too early and confuse people whilst the current carousel format is running. So there will be an increasing emphasis as we go into later summer, into the autumn, in the lead up to the new carousel implementation. More material will come out, and it will be highlighted to both candidates and the examiners.
It would be fair to say, those of you examiners who listen to this webinar, you'll be very well prepared to answer Stuart's question, and you will pass first attempt. Sanjeet Bataria is asking, if I don't pass in the first attempt, will I still have priority? Priority is not determined by when you apply, how many times you apply. It is about your eligibility. If your eligibility is coming to an end, we will still give you priority and try to accommodate you if you are unlucky to pass during your last attempt. So the questions seem to have slowed down. At least we still have a few more minutes about this. So maybe we can just re-emphasize that although it's changing, if you look at it from the examiners and candidates' point of view, we just would like to reassure you that the changes are really minimal. Often Stuart summarizes them that only two things are changing. You want to do that? Favorite one? Yeah.
There remain 8 encounters. 4 of them are the same. 4 of the encounters are unchanged. The sequence may have changed, but the actual encounters are unchanged. So you will still, as a candidate, be asked to examine a patient with a respiratory complaint, with an abdominal complaint, with a cardiovascular complaint, and a neurological complaint. So 4 out of the 8 are completely unchanged. 2 of the 8 are very similar to the current station 4, but shortened. So 2 of the encounters are similar to a current encounter, but shortened. And then the other 2 encounters are very similar to the B3C5, but they're lengthened. So it's 4 unchanged, 2 similar but shortened, 2 similar but longer. And that's it almost in a nutshell.
Yeah, the number of skills remain the same, this called the same, ABC2G, and the passing system of satisfactory, unsatisfactory borderline remains the same, and calibration procedure, as Stuart alluded to earlier, will also remain the same. So another question has come through, and let's see what they're saying. Idris Khalud again.
Has the new format been piloted internationally? So yeah, it ran in Singapore. Tanzim's predecessor, Donald Farker, ran it in Singapore, and it seemed to go down well. All of the you can answer the international centres and the dummy runs which are going on.
Currently, in the current diet, all those international centres, except for Singapore and Dubai, who are running exam, they're also running a mock exam. So it's a kind of training towards PACES23, but it also feed back. Exam is not static. PACES 2020 as it was an improvement of PACES and PACES, which came 10 years previously, and PACES has come 10 years before that. So we keep getting feedback. There's a lot of machinery in the background and people working very diligently on every aspect, and it will get reviewed again. And if there's anything that will come up, I'm sure we'll address that.
And I would emphasise as well that currently the Station 2 and Station 4 scenarios are all subject to scrutiny through the appropriate board, and some of the scenarios, if they're not performing well, they will be discarded. Other scenarios, there will be feedback from examiners giving advice as to what may or may need to change, may or may not need to change with the scenario. So scenarios do get updated on a regular basis.
And if there are any hosts listening, it may be just to re-emphasize that the Station 2 and 5 scenarios will be produced by yourselves, as you do currently for Station 5. You have a flexibility and you can beef them up a bit. They will be vetted. And as Stuart was saying, if you have a suitable patient and you can't produce scenario, we might be able to provide you from our central bank. The idea is that in future, probably more and more scenarios will be centralized. Yeah. It will be, time will tell whether we can actually achieve that, because each patient may be slightly different. Internationally, it may be a little bit easier because somebody else will be giving history in English, where the patient is there to be examined. So that is about Station 5 and 2. About these short communications scenarios, because that's a different thing. The only thing that is changing, as Stuart said earlier, is that you have 10 minutes of encounter. For each station, there was another question I just recalled. Reading time will be exactly 5 minutes. So you have 5 minutes, again, they will have 5 minutes to read this scenario, prepare themselves. They'll be able to make notes. They'll be able to bring those notes into the exam as they do currently, but then we expect them to be left behind. And so 5 minutes, we think, is adequate in that worked out in pilot as well. So we do not have any more questions. We can
just to emphasise again that this is being recorded and it will be available on the website. Any questions that come in subsequent to this, we will certainly try and answer them on a personal basis. But I think we're almost at the end of questions now, and we recognise that, for example, if you're in Hong Kong or Singapore, it is now midnight probably, something like that. Yeah, we're quite late.
There have been quite a lot of questions, so thank you very much for people who've been feeding into questions, and we've made an effort, hopefully, answer as many as possible. But as Stuart is saying, if there are still questions coming through when we go off air, they will be recorded and they will be replied. All this webinar will remain live on the MRCP PACES23 website, and people will be able to access it as well. And before we go off, I would like to again offer apology, like Stuart did in the beginning, for that the technical hitches in the beginning delay. We were all ready to go exactly at 1400 hours, but then suddenly we couldn't. So thank you for bearing up with it, and thank you for your participation.
So if you are an examiner, we really appreciate the time and effort you put into examining on a voluntary basis. If you're a candidate, well, I hope this helps you in your preparation. Your preparation shouldn't really be too different to what you would be doing currently, but we hope you find the material beneficial. And, you know, we wish you good luck in the exam.
So 2 new questions have come up while we were talking, and we still have a time. So one is, as an international candidate from Iraq, which center can accept local candidates as to not waste my 4 choices? So for Iraqi candidates specifically, we have 10 ring-fence places in Jordan, in Amman. So if you apply for that, you have more chance of getting selected there. If earlier you apply, you have more chances to get accepted for for Oman in Jordan. So, the other question from Lok about the giving instruction to patient in local language on clinical examination, chest, abdomen, cardiovascular, neurological examination. Yes, you can say to them, sit up or lie down or take a deep breath in your own language. We always have a local examiner as well. And if you start asking, tell me what your diagnosis is, we would know. But in the rest of the station, communication stations and history taking, you have to speak in English. So I think there's one more question come through before we go. And
please open a centre in Bangladesh.
Saklan,
he's working hard on it.
I'm coming to Dhaka on 15th of June. Hopefully, we'll have a centre there soon. With that, I think we will.
Do you want to say briefly about what's involved in setting up a new international centre?
Yeah, I think
it's not a straightforward process.
Thank you for reminding me.
There are quite a number of hoops to jump through.
Yeah, so the way it happens is once the discussion starts, it takes about 18 months in total. Saklan said again. So initially, we do a lot of research in the background, and then we do a fact finder where myself as the International Medical Director, sometime another colleague will come to this exam, make sure the center, we look at the place, we make sure that there are enough examiners and pool of patients. Once that is adequate, then we go for next step, which is called Pathfinder, where we run a full dress rehearsal of the exam. And if that goes well and we find enough examiners, we also train local examiners, and then the exam starts. So it can take a year or more for a new center to be up and running. So that we have to do that because it's very high stake exam. It requires, we have to be very diligent that once we open a center, it is able to deliver the standard that we aspire to and want to adhere to.
And we need to have a willing federation lead.
Absolutely.
We do very much.
We can't do without them.
We very much do rely on our federation leads across the globe. They do an excellent job on behalf of MRCP UK.
So it appears that there's no more new questions, so we may take leave from the audience.
Yeah. Okay, so thank you very much, everybody, from us here in London and wherever you are. Have a pleasant weekend.
Same for me. And some people are examining over the weekend, except me in Islam, but I know. I hope it will go well. Thank you.